Today's talk would be on deformation, disruption, malformation, and teratogenesis. These are your learning outcomes. To describe and distinguish between deformations, disruptions, and malformations, discuss the causes of malformations, discuss teratogens and their effects. This slide shows an overview of health and disease. There are factors that can affect a person's health status. These factors can affect an individual at any stage of their life. These effects can result in changes in growth, regeneration, repair, etc. They can affect at the cell level, at the organ level, at the whole body level. It helps determine a person's quality of life and their lifespan. It can result in good health, death, or disease. And because the individual is a part of a society and a population, all these effects can have an effect on the population health statistics. The slide also shows that intervention can be done at various points. The red boxes show the areas that we will be covering in this lecture. Human beings have a set pattern of development. The sperm and egg will fuse to form a single cell. The single cell will divide and form a ball of cells. This ball of cells will grow and mature and get organized into an embryo that becomes a fetus, which is then born as a newborn. The first 12 weeks of life in the womb is called the first trimester. It's also known as the germinal and embryo stage. In this stage, there is an increase in cell numbers. Cells will differentiate. Tissue and organs are formed. There's maturation of cell, tissue, and organ, and a growth in size. In the second trimester and third trimester in the womb, this is known as the fetal stage. In this stage, there's maturation of cells, tissue, and organ, and growth. There are things that can go wrong during development in the womb. This can result in deformation, disruption, malformation, and growth abnormalities. A deformation is a defect that arises as a result of a non-disruptive mechanical force on a normal tissue or structure. An example of a non-disruptive mechanical force is having another fetus in the womb, example twins or triplets. An example of a deformation is a twin's positional deformation that is caused because the other twin has been pressing on that twin's foot while in the womb. Disruption is a defect that arises as a result of a breakdown in or interference with a normal developmental process. So an example is amniotic band syndrome. In this syndrome, amniotic bands can constrict fingers, limbs, and other body parts to result in an abnormality in development. A malformation is a defect that arises as a result of intrinsically abnormal tissues. That is, cell differentiation, tissue formation, organogenesis has gone wrong. This usually arises during embryogenesis. Malformations can be classified into minor or major malformations. Major malformation occurs in about 2 to 4% of newborns, and a major malformation is one that is medically or socially significant. Malformations can be single, isolated, or they be part of a syndrome, meaning that a person can have more than one malformation. There are many different types of malformations known to occur in the human being. This is just a list of some of the possible malformations. And as you can see, almost every body system can be affected by a malformation. These are some of the real clinical situations we face. We sometimes see a baby born with multiple birth defects. Parents will have the question, what is the cause? What is the outlook for this baby? And will it happen again in the next child? Up to about 50% of malformations have no known cause. In the rest, it's either genetic or non-genetic. The genetic causes can be single gene disorders, chromosomal disorders, mitochondrial genome disorders, or multifactorial or complex traits. The non-genetic causes are teratogens, and we will go on to cover more of this in this lecture. A teratogen is an environmental factor that can result in deviant development of the embryo or fetus, meaning death, growth retardation, malformation, or a functional defect in an embryo or fetus. Teratogenesis is the process by which teratogens work. It is clinically important for us to identify teratogens. This is because teratogenic disorders can be prevented. Teratogenic disorders are non-genetic, hence the affected person cannot transmit the disorder to the next generation. Teratogenic disorders can resemble genetic disorders, so the failure to distinguish between the two can lead to inappropriate prediction of the risk of recurrence for that person. There are 6 principles of teratogenesis. Susceptibility to teratogens depends on the genetic makeup of the conceptus or individual and its interaction with the teratogen. 2. Susceptibility to teratogens varies depending on the developmental stage at the time of exposure. There are certain critical periods of susceptibility to teratogens. Teratogenic agents act in specific ways on developing cells and tissues to initiate the sequences of abnormal development events. The nature of teratogen and its route of exposure affects its ability to cause deviant development. There are 4 manifestations of deviant development. The manifestations increase in frequency and degree as dosage increases. Observational data suggests that humans have differences in susceptibilities when exposed to the same teratogen. The possible mechanism may involve the mother and/or the fetus's genetic makeup. This may determine the ability to inactivate a teratogen and hence determine their susceptibility to the teratogen. Susceptibility to teratogens varies depending on the developmental stage at the time of exposure. When exposed during embryonic life, in the first 2 weeks of conception, the conceptus is resistant to teratogens. The conceptus is most susceptible to teratogens during the 3rd to 10th weeks of conception. Exposure during this period can result in death, growth retardation, malformations, and functional defects such as alteration of maturations of tissues. Exposure during fetal life can result in death, growth disturbances, and alteration of maturation of tissues. It is unlikely to cause malformation as organogenesis has been completed. Teratogenic agents act in specific ways on developing cells and tissues. These specific ways can be those that affect cell death, those that reduce biosynthesis and therefore affecting growth, development, and maturation, and those that impede movement needed for morphogenesis. There are, of course, ways that we may not understand about teratogenic mechanisms at this point in time. The nature of teratogen and the route of exposure affects its ability to cause malformation. The agent can be a physical agent or a chemical agent. The route of exposure can be from the environment or from the mother. And via the mother, it can come through the mother's skin or the mother's bloodstream. There are 4 manifestations of deviant development: death, growth retardation, malformation, and functional defect. The manifestations of deviant development increase in frequency and degree as the dosage increases. The range can range from no observable adverse effect to 100% lethality. So what are the common teratogens? There are drugs and toxins as listed in the slide. Congenital infections. It can be things that come from the environment. It can be maternal conditions. So we are going to discuss all these in the following part of this talk. So let's start with teratogenic drugs and toxins. The first drug that I would like to talk to you about is thalidomide. Thalidomide was invented for use to control nausea during pregnancy. nausea and vomiting during pregnancy most frequently occurs in the first trimester. Exposure during the first trimester was observed to cause limb abnormalities and face abnormalities. It was Dr. McBride who first raised the alarm in 1961 when he observed that there were women who had abnormal children. Between 1957 and 1962, more than 10,000 babies were born with physical abnormalities. Thalidomide was the drug that was responsible for us as a society coming up with stricter regulations for the approval of new drugs and vaccines. Thalidomide fell out of favor for many years, but now thalidomide is back for use, but not as a way to control nausea or vomiting during pregnancy. It is for use for us as an immunomodulator. It works very well, and when we give it to patients, we give them advice not to get pregnant while on thalidomide. Alcohol or ethanol is one of the most potent and readily available teratogen. There is a vulnerable window period for the fetus and embryo. There is no safe amount of alcohol. Alcohol shows a dosage effect. If a woman drinks more than 2 drinks a day in the first trimester, 30 to 40% of the babies will have full-blown fetal alcohol syndrome. Fetal alcohol syndrome has a strict criteria for diagnosis. It involves multiple systems where we are looking at growth abnormality, there are CNS abnormality, and the baby may be dysmorphic. And there usually needs to be a significant exposure to alcohol. Let's talk about anti-epileptic drugs. Valproate, phenobarbital, phenytoin, carbamazepine, and lamotrigine increase the risk for major congenital malformations as well as cognitive and behavioral issues. We should avoid these drugs if possible. We should try to switch the patients to alternatives. If it is not possible to avoid these drugs, we should reduce the dose because the effects are dose-dependent. For those on valproate and carbamazepine, folate supplementation prior to conception and during the first trimester can reduce some of these risks. Statins are absolutely contraindicated during pregnancy because the drugs may cause disruption of fetal cholesterol biosynthesis. Cholesterol biosynthesis is important for cell membrane morphogenesis as well as the production of other important hormones. Reported birth defects include limb malformations, congenital heart defects, and CNS abnormalities. ACE inhibitors and ARBs are frequently used to control blood pressure and protein loss in kidneys. The use of these drugs during pregnancy increases the risk of embryonal and fetal abnormalities. They may also adversely affect the mother's health. Warfarin increases the risk of brain, skeletal, and growth abnormalities, and sometimes we will call this warfarin embryopathy. For some of the vitamin A derivatives, their oral or IV use can increase the risk for brain, face, and cardiac abnormalities. Androgenic hormones increases the risk of virilization of the genitalia of a female fetus. Lithium increases the risk for Epstein's abnormality of the heart. Cytotoxics increase the risk for fetal death, growth retardation, and malformation, especially when given in the first trimester. So how do you find out if a drug is safe for pregnant women? There are many resources. The important one is to read the package insert. This will come with the drug, or you can find them available online. You can look up PubMed, you can look up teratogen databases, or you can ask the pharmacy. It's very important because we doctors can prevent, or sadly can cause, drug-related teratogenic disorders. There are many drug and pregnancy risk classification systems. The one that is most frequently used is the FDA system. FDA used A, B, C, D, and X risk categories from 1975 to 2014. For drugs that were approved from 2015 onwards, They had narrative sections and subsections that included pregnancy, lactation, and effect on male and female reproductive potential. In Australia, they use a categorizing system for prescribing medicine, so A, B1, B2. In Germany, they have different categories naming from 1 to 11. We will go on now to the second group of teratogens, which are the teratogenic congenital infections. CMV is a common infection. The transmission is usually through close and intimate contact with a person who is excreting the virus. It can be also transmitted through sex, breast milk, organ transplantation, and the use of blood products. It can also be transmitted from mother to the unborn child. Most postnatal CMV infections are not diagnosed because the infection usually produces few or no symptoms. The percentage of childbearing women who are not immune to CMV varies from population to population. In Singapore, most women in the childbearing age are CMV positive. When a woman is infected during pregnancy, the virus in the woman's blood can cross the placenta and infect the embryo or fetus. The overall risk of embryo or fetal infection is 30 to 50%. Embryos infected during the first trimester are likely to be born with microcephaly, developmental delay, thrombocytopenia, and hepatosplenomegaly. Fetuses infected during the later part of pregnancy may not show obvious damage at birth. These babies, however, may present later on in life with deafness, developmental delay, and/or seizures. Toxoplasmosis is a parasitic infection. It is acquired by the ingestion of the parasite, for example, from infected meat that is undercooked, ingestion of infected cat feces. It can also be transmitted from mother to the unborn child. Infection in an adult may be asymptomatic or be associated with only mild symptoms. When a woman is infected during pregnancy, the virus in the woman's blood can cross the placenta and infect the embryo or fetus. The risk of infection is dependent on the gestational age of maternal infection. 15% risk in the first trimester, 25% risk in the second trimester, and 70% risk in the third trimester. The consequence is dependent on the gestational age at which the infection occurred. For embryos infected during the first trimester, most will have severe disease resulting in death or a newborn with severe central nervous system sequelae. For fetus infected during the second trimester, 50% of them will have similar severe disease as those infected during the first trimester. For fetus infected during the third trimester, most will not show any obvious signs or problems at birth. However, neurological sequelae and/or chorioretinitis may appear later on in life. A pregnant woman can get rubella infection if she is not immune against rubella. For example, she never got rubella infection, she was never vaccinated against rubella, or she was vaccinated but has vaccine failure. There are some concerns that congenital rubella infection can also occur if the MMR or MMRV vaccination was given during pregnancy. If a pregnant woman gets rubella infection, the risk of embryonal or fetal infection is dependent on the gestational age at which maternal infection occurs. The risk is 85% in the first trimester, 50% in the second trimester, and 25% in the third trimester. The consequence is dependent on the gestational age at which the infection occurred. For embryos infected during the first trimester, there are increased risks of miscarriage, premature delivery, or stillbirth. 50% will have congenital rubella syndrome at birth. The common features are microcephaly, intellectual disability, cataracts, deafness, congenital heart disease, thrombocytopenia, hepatosplenomegaly. For those infected between 13 to 16 weeks of gestation, 10 to 30% will have deafness and developmental delay. For those infected after 16 weeks of infection, it is rare for them to have problems. Almost all will be fine. Let us practice reading drug package inserts. Here is an extract from the MMR vaccine package insert. You can see 4.5 under pregnancy. Do not administer this vaccine to individuals who are pregnant or who are planning on becoming pregnant within the next month. Then you can read below what is the risk summary about receiving the vaccine during pregnancy. Syphilis is a sexually transmitted disease. An infected mother can transmit to the fetus at any time during pregnancy at any stage of syphilis. The risk is dependent on the number of spirochetes present in the maternal circulation. In primary and secondary syphilis, the number of spirochetes in the mother is high, hence the risk is high to the fetus or embryo. In tertiary syphilis, the number of spirochetes in the mother is low, hence the risk to the embryo or fetus is lower. If the mother is not treated in time and if the embryo or fetus is infected, this may result in miscarriage, intrauterine growth retardation, non-immune hydrops, stillbirths, premature birth, death during infancy, or babies with significant health problems that can include deformities, delays in development, seizures, rash, fever, swollen liver and spleen, anemia, and jaundice. If a mother has syphilis, her treatment can start the moment the infection is detected, even during pregnancy. Treating the pregnant mother will also treat the infection in the fetus because the drug can cross the placenta. Treatment of the infected fetus will not reverse any damage already done to the fetus, but can prevent further damage. If the baby was not treated while in utero, the baby needs treatment the minute the diagnosis is made after birth. Varicella, also known as chickenpox. The risk of fetal infection depends upon the gestational age at which maternal infection occurs. If the pregnant woman gets infected during the second trimester, the risk of fetal infection is low, but can result in eye, skin, limbs, CNS abnormalities. If a woman gets infected 5 days before delivery or within 2 weeks after delivery, the baby is at high risk of severe varicella infection and should get a specific treatment like VZ immunoglobulin and acyclovir to preserve the baby's life. Parvovirus is a virus that commonly infects human beings. It is transmitted via direct or indirect contact with airborne droplets. About half of the pregnant women are already immune to parvovirus B19. Pregnant women who are not immune, when infected, usually have only mild illness. Thankfully, their babies usually do not have any problems, but rarely the fetus or baby can have severe anemia. The risk seems to be higher if the infection happens during the first half of the pregnancy. Zika. So Zika is a virus that's transmitted by Aedes mosquito and through sex. Only 1 in 5 infected persons will actually be symptomatic. Pregnant women are not more likely than non-pregnant women to get Zika infection. If a pregnant woman is infected, the Zika virus can cause microcephaly in a certain number of unborn fetuses, but we don't know the full spectrum of the disorder. COVID-19 infection and the risk to the unborn child is still being studied. But we do know that the pregnant woman tends to get more severe illness than the non-pregnant women. We know that the COVID-19 vaccine so far is safe, so MOH has said that we should try to encourage pregnant women to get vaccinated if they are not already vaccinated, and that the vaccine is safe for women who are breastfeeding. It is important for us to prevent congenital infections. Here are some of the ways. We can recommend that women be vaccinated against rubella and chickenpox before they get pregnant. We can recommend that pregnant women practice good personal care and hygiene, good hand hygiene, no ingestion of undercooked meats, no handling of cat feces, take precautions against droplet transmission, oral transmission, vector-borne infection, to go for checkups and screen for STDs before getting pregnant, and if a woman has syphilis, to treat it as soon as possible. Let's talk about teratogenic environmental exposures. One of the environmental exposure is smoking. There are many harmful effects of smoking while pregnant. This can include miscarriage, stillbirth, ectopic pregnancy, birth defects, premature birth, low birth weight, sudden infant death, and increased risk of infant mortality. The best advice to pregnant women is not to smoke, and if a woman is smoking, to stop smoking. Methyl mercury exposure comes mainly from fish. The FDA recommends that pregnant and nursing women, as well as young children, do not eat any shark, swordfish, tarfish, or king mackerel, as these fishes have high methyl mercury content. The EPA recommends that pregnant women eat up to 8 ounces of any fish per week, except for those fish mentioned above. Methyl mercury poisoning can cause CNS sequelae in the child, learning disability, developmental delay. PCBs were previously widely used. They were banned in the 1970s, but because they are very stable, they persist in the environment. Most human exposure to PCBs come from eating fish, with dairy and meat products contributing to some extent. Once inside the body, the PCB remain a human fat for more than 25 years, and humans are the slowest to excrete and eliminate PCBs, and there is no way to speed this up. In utero, exposure to PCBs can cause a spectrum of illness ranging from learning disabilities to low birth weight, gum discoloration, skin discoloration, and nail discoloration. Ionizing radiation can be received in small doses without causing major problems, but we should avoid if possible. In large doses, they can cause microcephaly and intellectual disability in the unborn child. Fetal thyroid starts concentrating iodine after the 13th week of pregnancy. Hence, radioactive iodine given after this period carries the risk of irradiating the fetal thyroid, giving rise to in utero hypothyroidism, leading to mental and growth retardation. Sources of radioactive iodine can be from us treating individuals for certain types of thyroid disease, or from the environment, for example, nuclear power plant meltdowns, nuclear bomb explosions. We should try to anticipate and prevent environmental exposure. So here are some ways to keep in mind. Always ask a woman if she's pregnant before you expose her to anything potentially teratogenic. Example, ask her for her last menstrual period before doing any x-rays. We can always ask a woman if she is smoking, and if she's smoking, we can give her anticipatory guidance on the benefit of stopping and also refer her to smoking cessation programs. Let's go on to teratogenic maternal conditions. So one of the more common is diabetes in the first trimester. Exposure to uncontrolled hypoglycemia during the first trimester confers increased risk for malformations that will affect the heart, the skeletal, and the central nervous system. And the pathognomonic malformation is Teratogenesis. So you can see in this picture, the sacrum is missing from the child. Good control of blood sugar prior to conception and during the first trimester will greatly decrease this risk. But if you have too much good control, meaning that the mother is hypoglycemic, you can also give rise to malformations. More commonly, diabetes will occur in the later part of pregnancy. Again, exposure to uncontrolled hypoglycemia can cause disturbances in growth and tissue regulation rather than malformations. So the baby can have hypertrophic cardiomyopathy, fetal overgrowth, polycythemia, postnatal hypoglycemia, postnatal hypocalcemia. Good control during the later part of pregnancy reduces these complications, but excessive control can lead to inadequate fetal growth. SLE is quite common amongst our local women, and their disease is more severe than that seen in Western countries. The increased risk to the fetus or embryo is related to SLE as well as the drugs used to control it. There's increased risk for fetal loss and prematurity, increased risk for neonatal lupus syndrome, increased risk for congenital heart block. Hypothermia in the first trimester carries a small increased risk for cardiovascular defects as well as neurotube defects. We can try to prevent it by limiting exposure to hot environment, reducing the risk of getting febrile illness, treating the fever but perhaps judiciously because some of the drugs may also be of concerns for teratogenic effects. These are the areas that we have covered today. And thank you, and please go on to the quiz questions.